But in your folder, we collaborated on a film called The Edge of Joy, a documentary film, and it was filmed in Nigeria, going to some of our project sites, but really identifies very well, I think, the challenges that families face in trying to get obstetric care and the challenges that providers face as well. So you have, what you have is sort of a voucher for that film. It's not readily available, but it is available for you for a limited time only. You see the one that says The Edge of Joy on it. So it gives you a password to access the film. Okay, May?
The first presenter on our afternoon agenda is Dr. Suellen Miller. I don't think that I need to introduce her to you again. Anyway, this group of, as I said earlier in the morning, the anti-shock garment has been called a miracle, but it can bring about miracles only if support systems are in place. The anti-shock garment is only a part of the solution. Our next group of presenters will talk about the support systems that need to be in place to close the loop. I'd like to invite Dr. Miller for her presentation.
I think I need some help just getting this started. And I need to state right away that I'm not the originator of this presentation. Ellen Israel, our colleague from Pathfinder International, was to do this presentation. Unfortunately, she wasn't able to come, so I'm merely the voice of her presentation. So as you saw from the video, there's training that can be done in person, and then there's training that could be followed up with the video. So trainers could go and train according to the PPH curriculum that Pathfinder has produced, and then leave the CD with all the information on it there. But one of the steps that we've found to be particularly helpful is conducting drills. We do this as part of the PPH curriculum training. So during the training, there's actually drills that are part of it. And then we expect that drills will continue afterwards. In California right now, the California Maternal Quality Care Consortium, of which I'm a member, which is high-level referral facilities in the state of California, have instituted drills in all of their referral facilities. They expect that because postpartum hemorrhage, real postpartum hemorrhage, is a rare event, that staff really need to be trained to react immediately. And having drills allows the staff to work together as a team, to figure out roles, to have materials in place, and having this realistic event go on. So the steps in management of PPH are, finding the cause of the hemorrhage, we call it the 4 T's, and then treating the cause, preventing shock from happening, and then if shock does happen, treating shock. So this is what we built into the PPH training, and we do drills on all of those activities. So a clinical drill, what do we mean by that? A trainer or staff within the hospital will arrange examples of blood loss, write some scenarios, and then have the staff who actually would be treating this go through a step-by-step process of actually managing and treating it. And this is a way of getting around the fact that PPH and shock, especially massive shock hemorrhage, is rare enough. We want everyone to have their skills together and be able to react. And so we think that these drills are an important piece. They should be being done during pre-service training, although that's something that in some ways are out of our hands, since it's sometimes the Department of Education or the Ministry of Education who determines that. But certainly in the in-service training that we do, and then during our supportive supervision visits, it can be unplanned and or planned, and that will then maintain a level of skills that would otherwise be impossible. Having it be a drill is so much different than just showing one skill. You have to get all the steps together, and you have to do them in the right order, and you have to understand the rationale. I think we already said it's not a routine event. If you've instituted procedures in a facility, doing a drill may help you understand that what you thought out so carefully on paper back in an office somewhere may not actually work within the context that you're working in. So conducting these drills on site may make you realize that there has to be a modification. So this is very important that this be done in the place where it's going to be happening. You get people working together as a team and moving forward and realizing, as we showed in the video, this is not something one person can manage. There has to be a team approach. Roles need to be defined, because you also don't want everybody trying to massage the uterus or everybody trying to remove the placenta. The roles have to be clear. A team leader has to be discovered. Somebody has to manage the entire event. And then taking theory to practice, really being sure that what people say they understand and can pass on a written test as knowledge, they really have the skills to be able to perform. So the elements of these effective clinical drills. One is having scenarios that are very realistic. You lay out all the information for the person, gravity, parity, why she might be bleeding, and then what can and should be done, and make it realistic to the level of the facility in which, or home, that people are going to be practicing. They should also be done in real time. So it's not the person starts to do something and then goes, oh no, I didn't mean that, I should go back and do that over again. This is as realistic as possible. We have the clock ticking, and in some cases we have the pretend patient die. The result being that if you don't act, and you don't act quickly, in this kind of setting, you can lose the patient. So the urgency has to be there. And then we have the things that I mentioned, the teamwork and the required equipment. This can be done with models. There are a number of gynecological obstetrical models that can be used that are quite expensive. And then what's shown here is a device that's called Parto Pants, which is quite cute. And I've given you a website. You take a pair of scrub pants or any other pants, and then you build in a vagina and a pubic bone and a sac that you put fake blood in, and a little tube, and you can fill up a certain amount of blood, and when the clock starts ticking, you can actually have a certain amount of blood being released per minute, so that once the patient has exsanguinated, obviously you've got a pretty real situation. In terms of emergency management, what we've done sometimes in the training, I noticed that I think we shouldn't be doing, is assembling equipment for the trainees. In the real on-site training, you shouldn't provide anything. People should know where they're going to get their materials. Do they have what we would call a crash cart? Do they have the emergency equipment nearby? Are they able to start the IV with a wide gauge catheter? So those things, having those things and knowing where to find them, are really important parts of the drill. And having it be more than just the team working on it and one person would be to have some colleagues around as well. I think I just missed something. Yeah, conducting it in front of trainees so that people are actually observing and are able to take part in a critique, and there can be feedback to reinforce the correct practices and to correct mistakes, not in a punitive way. And here we are again with the Parto Pants, this time documenting bimanual compression. So these are hand skills. There's actually a little uterus in there that a person can, if they haven't ever felt what it's like when you start compressing the uterus, you can get it to contract. A good skill to be able to have. So these clinical drills should be a component of the clinical trainings, include in protocols and standards of practice, and make sure that this is part of continuing competency, and link these clinical drills to procedures that are related to emergency referral. The drill steps are to set the stage by writing a realistic scenario. And in the pages that I've given you to link to, they actually have some scenarios all written up. So you can have some pretty realistic scenarios. You take the group that's going to be learning these activities together and you brief them. And then you have the team decide what roles they're going to play. And then they go. You start the clock and they experience the scenario with no interruptions. You're not calling them and saying, no, you're not supposed to do that, or this is supposed to happen first. You know, the only thing is that the pretend patient, for let's say who's wearing these Pardo pants, responds appropriately. If the wrong things are done, she keeps on bleeding. So that's a way of enforcing and reinforcing proper steps. After the situation has been resolved, then you follow it with a guided debriefing, and people can express what was learned, what their feelings were, and problem solve how to avoid problems in the future. What I've been saying about the timing part of it and the urgency and having a pretend patient makes this pretty real. So if you're the instructor or the facilitator or the guide, people may have some strong responses to this in a way that's different than a role play where people kind of get into the drama and they're acting out. When this patient keeps on bleeding and the uterus doesn't contract no matter what you do, it's not the same as with a real patient, but it can bring up some pretty strong feelings. So I don't want to make this into something too light. You do need to react to what people's responses are. And that's it. Thanks.
Our next presenter is Dr. Farooq Jaga. Dr. Jaga is the program manager of the MacArthur Foundation-funded Clinical and Community Actions to Address Postpartum Hemorrhage project at Pathfinder International's country office in Abuja, Nigeria. Before joining Pathfinder, Dr. Jaga was a senior specialist registrar in obstetrics and gynecology at the National Hospital, Abuja, Nigeria, and a consultant for the UNFPA field office in Nigeria and Gujarat Ministry of Health and Family Welfare in India. Dr. Jaga has 15 years of experience in sexual and reproductive health programming and evaluation. Please welcome Dr. Jaga.
Good afternoon. I'm talking about some of the challenges we face in treating cases of postpartum hemorrhage in the CCPPH project in Nigeria. I think it has been said many times that the anti-shock garment is not definitive treatment for PPH. And this is really one of the biggest challenges that we face from policymakers, from politicians in Nigeria. Everybody wants this new, brilliant piece of technology, and they have a feeling that once they get it deployed in the hospital there, then it's going to, treat all the women with postpartum hemorrhage, even when they don't have the other critical, equipment and supplies like blood, like uterotonics, like even appropriate staff in the hospitals that are needed. We understand that NASG, it's a very good tool that helps to stabilize the patient that is in shock. But in most instances, you do need further treatment in the form of intravenous crystalloid solutions, in the form of blood transfusion, uterotonics, or even surgical procedure. Now, the immediate priority for a patient that suffers massive postpartum hemorrhage, obviously, is volume expansion. And this can be in the interim with appropriate intravenous crystalloid solutions, and then, of course, later on with appropriate blood or blood products transfusion. Now, most women that die from postpartum hemorrhage in Nigeria are as a result of not receiving appropriate uterotonics solutions or blood within a reasonable period of time. There are often very, very, very long delays before they get this required treatment. And this is either because the appropriate IV solution, it's not available, or the blood also that is very, very critical is also not available. Uterotonics is also another very big challenge that we face, and it can be either non-availability or instability, or not being quite potent. I think we had some discussions this afternoon. There are huge challenges with electricity supply in the country. So you find that oxytocin is usually not stored in refrigerators. And most of it, providers will tell you that sometimes they use up to 80 to 100 units, international units, before they get an effect. Misoprostol, that is supposed to be a very, very good alternative in such situations, unfortunately, is not accepted in most parts of the country because it is still being stigmatized as an abortion pill. Now, the National Blood Transfusion Service in the country, it's supposed to be the agency that should take the lead in ensuring that there are adequate, blood and blood products. Unfortunately, this agency is still grossly underfunded, so there are still very, very big problems with getting adequate blood for transfusion. A typical scenario is that if a woman comes in bleeding, usually it's the relations, one or relation or the husband or the sisters or the brothers or colleagues that would go to the laboratory. They become screened, and then they get, if they cross-match them if they have the same blood group. They take a sample and screen them if they are HIV and hepatitis negative. Then they go on to get bled. This usually takes a long time, really, and it's one of the major causes of delays in getting blood. Oftentimes, too, the relations are not even willing to donate. We have seen cases where husbands are not willing to donate to their wives. They tell the lab people that, we can buy it. If it's 1,000 naira, if it's 2,000 naira, we have the money to buy it. But they don't want to donate themselves because obviously there are very huge issues with stigma for HIV, because they don't want to know their status, or because they are really ignorant and they believe that they don't have enough blood themselves. So if they donate, then they are going to get sick as well. Now, one of the things that we have done to address some of these challenges, especially with blood, is to form what we call emergency blood. And this we did with technical assistance from Hadi, our colleague here. We first piloted it in Katsina. And what we basically did was to help these small blood banks to keep at least 5 to 10 pints of blood in the blood bank or in the laboratory, exclusively for maternity obstetric emergencies. Such that if a woman comes with bleeding, then she doesn't have to wait all that length of time before they get a suitable donor. She gets the blood, but she gets to reimburse the number of pints she gets before being discharged from the hospital. Obviously, there are still challenges with getting them to, donate once they get well. But I think we have been able to work a system between the hospital, the maternity, and the blood bank to somehow get it replaced at very, very low cost. We have also been able to set up a model solar blood bank with generous funding from the Cloverleaf Foundation. And this was done in a general hospital, that's a secondary health facility, where there was absolutely no blood bank whatsoever in the past. And before, 6 months earlier, women with PPH or any kind of bleeding, or even anemia in pregnancy, had to be referred like 40, 50 miles to get blood transfusion. But with this intervention now, the last time I checked, about 2 months ago, there were over 100 units of blood in this blood bank. And the amazing thing, it's all solar powered, so it does not require any electricity for storage. The community is just around now being mobilized to come forward to donate blood, and so on, so that it can be a sustainable system. I will talk a little bit about surgery for postpartum hemorrhage with the anti-shock garment in place. And I think this is also one of the big challenges that we face. A lot of providers, I think Suellen had mentioned the complacency, that happens. And it's really very real, And there's also another dimension to it, that there are lots and lots of training gaps, Some frontline medical officers who do most of the work for treating these patients do not actually have the adequate skills to manage these patients appropriately. For vaginal surgeries like manual removal of placenta or evacuation of retained products, you don't really need to remove the anti-shock garment. I think it was said in the training video that we watched. And this can be done quite comfortably by most of our providers. Where we really have the challenges is in treating patients with intractable PPH, where everything has been done. They have had uterotonics, they have had bimanual compression, and the surgeon or the attending physician has decided that some form of surgical intervention is needed. Now, what comes quite to mind, obviously, because doing uterine devascularization procedure is quite complex and difficult, even for trained OBGYNs. I'm not sure it's everybody that has the skills to do those ones. Most medical officers would quite easily just go and remove the uterus and do a hysterectomy. And I think Suellen has already discussed that this is a huge morbidity indicator, especially in traditional settings in Nigeria, where women place a very, very high premium on childbirth and monthly menstruation, for cultural and religious purposes. So, because of that, we introduced something that is really not very new, but it's still relatively new in Nigeria. I think it's still catching on. The concept of these compression sutures. They are really a very conservative way to treat atonic postpartum hemorrhage without necessarily having to go the whole hog by removing the uterus. There are different types of compression sutures that have been described, and all use the same principle of exerting continuous vertical pressure on the uterine vascular system. And if the bleeding is due to uterine atony, as indeed it is in over 80%, 70 to 80% of cases of PPH, then this should really control the bleeding. I will describe briefly the B-Lynch suture, which is one of the uterine compression sutures, and which is the one that we are really very comfortable, using and teaching primary physicians in Nigeria. The B-Lynch sutures are also called brace sutures because I will show you a picture that shows actually like suspenders. It's actually like putting a pair of suspenders on the uterus. So that's why they are also called brace sutures. They were first applied for a patient with massive postpartum hemorrhage in the UK who refused consent for hysterectomy. And they were described by an OBGYN called Christopher B. Lynch. And they have gone slight modifications over the years, but the basic principle is still the same. So obviously a hysterotomy or an incision, just like a cesarean section to get access to the uterus, is required for two main reasons. One, it's to make sure that the uterine cavity is empty completely, that there are no retained products, which can also cause uterine atony and also cause PPH. And then the other reason is to be able to put the needle in here and then out, and then slide it over the top of the uterus to the back, and that's the back. And then you get back in here and then come out here, and then you do the same for the other side. And it's really like putting a pair of suspenders on the uterus. And if you understand the anatomy of the uterine vascular system, then you would see that they put, a compression pressure on the uterus. And in most cases, this is just enough to stop bleeding, particularly if the PPH is due to uterine atony. That one has got to be understood. this is the same picture, but, showing it on the other side. This procedure now has been done for over 20 years, and there is a lot of data that has been collected by the person that first described this procedure. And to date, there has been no major complications reported with this procedure. And most importantly, especially for Nigerian women, there has been many, many reported cases of successful future pregnancies and even deliveries without any complications. Just some few clinical points on the B-Lynch suture. Just basic surgical competence is required. Any medical officer that can perform a cesarean section can also be able to perform this one. It's really not a big deal to do. It's also important that before placing the sutures, the surgeon does, or an assistant at least, does bimanual compression of the uterus, because it's a test for efficacy. So if bimanual compression of the uterus does not work in stopping the hemorrhage, then it is not likely that compression sutures are going to be useful. So I think that's also another very good utility for this. It's simple and cost-effective. It has the potential, actually, to be used prophylactically for those women that have maybe placenta accreta or placenta previa, or any of the risk factors for PPH. Unfortunately, it is still, doctors in Nigeria are still not very confident doing this procedure because it's relatively new, and unfortunately there are not many opportunities to train, surgeons on live patients for this procedure. Well, I will conclude by saying that this procedure, at least the B-Lynch variety of compression suture, has been recommended in the UK Triennial Confidential Inquiry for the year 2000 to 2002, and it has also been recommended by the Royal College of Obstetricians and Gynecologists, and it is indeed in the Cochrane database of systematic reviews. It's a simple and safe procedure. It's particularly useful in Nigeria, where women place this high premium on maintaining their uteruses for childbirth and for menstruation. And also to conclude by saying that the NASG is not definitive treatment for PPH. The definitive treatment in most of the cases are namely blood transfusion and or performing surgery for atonic PPH are the most difficult elements of the continuum of care that we find in Nigeria. Thank you very much.
Our third presenter is Dr. Blami Dao. He is the Director of Maternal and Newborn Health, Japigo. Dr. Dao is an obstetrician gynecologist trained at the University of Dakar in Senegal with 15 years of field experience. Before joining Japigo in December 2010, he was Vice Dean of the School of Medicine at the Polytechnic University of Bobo Dioulasso and head of the Department of Obstetrics and Gynecology at Suro Sanu University Teaching Hospital in Burkina Faso. His hospital was the first to introduce AMSL in Francophone Africa 10 years ago. He collaborated extensively with Genuity Health Projects on research for various indications of misoprostol, incomplete abortion, and PPH. Please welcome Dr. Dao.
Okay, thank you, everybody. I'm going to talk about implementing evidence-based PPH prevention and treatment. From all the presentation we had this morning, it became clear that there are solutions to prevent and treat PPH. However, every year we have 14,000 women who died from PPH. So what is the issue? I think the main issue is implementation. To address PPH in terms of prevention and treatment, we have clinical solution. This clinical solution fall under basic AMC or comprehensive EMOC. But we need also to address, we have basic EMOC and comprehensive EMOC. When you talk about basic, we have the use of heterotonics, bimanual compression, aortic compression, and manual removal of placenta. When it comes to comprehensive EMC, it is mainly blood transfusion and surgical procedures. But one must ask himself, what is the evidence behind this clinical intervention? I derive this from the WHO guideline published in 2009. When it comes to the quantification of blood loss, it seems that clinical quantification is better than trying to use blood measuring devices, what WHO said. Because the evidence is low, but it is a strong recommendation. When it comes to the use of heterotonic, the first line is oxytocin, the second ergometrin, and the third prostaglandin, we can say misoprostol. If PPH occurs after using AMCEL, as it is going to be the case these days in most of the country, because we have been promoting AMCEL for more than 10 years now, the WHO advised to use oxytocin alone instead of, in preference to adjunct misoprostol. When it comes to uterine massage, bimanual compression, external aortic compression, it seems that the evidence is very low to promote. But for uterine massage, as it is not really harmful, it is strongly recommended by WHO. When it comes to intrauterine balloon or condom tamponade, if heterotonic is not available or fail, the evidence is very low. In 2009, WHO didn't make any recommendation regarding non-anti-shock garment because they said they are waiting for study to come out. Suellen present today. I hope we'll be able to move on that. When you come to artery embolization, we know that it's really highly sophisticated procedure, which I am not sure even in most of African countries that can be done. They said the evidence is very low. They don't recommend it because the recommendation will be weak. When it comes to treating women who have shock, if we don't have blood, you can use crystalloid instead of colloid. Of course, from what we heard today, and all studies have been published since 2009, there is a need to update this guideline, definitely. I think it will going to be done in 2011. I also say that there are programmatic approaches. I am not going to elaborate too much on that. But I think if you want to have an impact really on PPH prevention and treatment, because what we notice that for more than 10 years I have been programmed trying to address the issue of problem. But at the country level, I have the impression, coming from the field, that we are not making really progress. There are small projects in each country, but now we need to scale up this intervention. If we need to do so, we need to have in each country what I call a national action plan to address PPH with three components: the policy level, the facility level, and the community level. As my intervention fall under clinical intervention, I'm not going to elaborate too much on policy and community level. I'm going to put more emphasis on at the facility level. At the facility level, I think there are some components at the policy level. There are some components which have clinical implication. One of the issues is the issue of oxytocin drugs. Because today we hear a lot, we need to have misoprostol registered in the country. We need to have misoprostol in the EML, essential medicine list. That is fine. Even if we do so, for me, I consider this to be the first step. because the most important thing is to have misoprostol available where it is needed. And to do that, we need to have at the country level a policy on oxytocin drug. The other issue is about storage of oxytocin drugs, oxytocin for instance. When you go to a facility, they have a refrigerator donated by UNICEF. But UNICEF said no other drug inside this refrigerator. It had to be used only for vaccine. That's something that does make sense. It's in the same facility, treating the same women, the same children, but they said our refrigerator is only for vaccine. The third issue about oxytocin drug is the quality of the drug. Because we know there are a lot of fake drugs. If misoprostol on the list of AML in these countries, people who are making fake drugs are going to jump in the business, selling fake misoprostol, and we will end up using misoprostol, but it's not working. One of the issues of the political, which have also a clinical implication, is the partnership between professional association and the Ministry of Health. Because these professional association members are the ones who are in the clinic. They are the ones who are teaching in schools. So it's important to bring them on board. At the facility level, we talk about training, but I think we must put emphasis on pre-service training, because there are so many in-service training going on in this country without any result, unfortunately. When we talk about pre-service training, that means we have to update the training material of people who are teaching in midwife school and nursing school and medical school. They are the ones who are going to the conference. They come back, they continue to teach the old things. There is also a need to have regular facility readiness assessment for obstetric complication, including the availability of PPH kit. In most of the country, we have PPH kit, but now maybe we need to add misoprostol, because it didn't have misoprostol. The last issue at the facility level is about regular supervision. Because if you don't supervise people, they don't do the thing right. Unfortunately, people are investing in training, but not investing in supervision. And the last issue to be solved is the monitoring and evaluation issue. I think that is very important. We need to have indicators at the policy level, at the community level, at the facility level to track the PPH issue. I would like to conclude saying that my mentor, Harshad, said the cause of death is not PPH, but the delay in treating PPH. I think that is really important. And if we want to have an impact to scale up, we need to have a continuum of action from the policy level to the community. Maybe, I don't know if it's a dream, we can launch a no PPH-related death campaign. Thank you very much.
As fast as you. Thank you. Please, thank you to our panelists. I think Dr. Dow's presentation maybe should have been entitled Reality Check. He definitely told us what it's like in the field and the challenges that all of these presenters and participants face in the field. Maybe I'd like to take one piece of what he said and do my own little reality check. And I'd like to hear from some of you or panelists as well. Dr. Dow showed us the WHO recommendations and how they view some of the interventions and innovations that we have been piloting through our programs. And I'd like to hear from some of you how these WHO recommendations affect you in the field. Do they make a difference? Does anybody pay attention? Has it slowed down the implementation of any of your programs?
Can I?
Please.
Yeah, absolutely. I think they do. I will talk specifically with reference to misoprostol use in the community. In Nigeria, for instance, I think this was one of the main reasons why, although we do know that there were some other maybe subterranean reasons why they didn't want misoprostol in the community, but they always hid behind the fact that the WHO had not approved the use of misoprostol for that, purposes. But I am glad to announce that just very recently the National Council on Health had approved the use of misoprostol for community PPH prevention, and this was based, I think, largely on behalf of the venture strategies ops research that was done in Nigeria, and a technical committee has just been set to bring up guidelines for the use of misoprostol in the community. I think this is one of the areas where WHO recommendations really hurt some of the work that we're doing.
I agree. Others? Debbie.
I can really appreciate that, and I think that this whole misoprostol issue, because it's a lot more complicated than it seems on the surface, and as you said, people hiding behind different things and not all the transparency that we would want. But I guess I would take the opposite tact in that I think without WHO having guidelines, when they weren't speaking at all, I think then we don't have anything in the field to push things forward. So while you're speaking particularly to meso at the community level, and I think you're right, there's been lots of confusion out there about that. The fact that we had PPH guidelines, which were only created, 2006, I think. Before that, what it did is it really put it up front. It was something you could go to, look, this is what WHO says we should do. We can use misoprostol. So I think that it was a double-edged sword. I think we needed them, and I think it's moved a lot of things forward, even though it probably has caused problems there. But with the continued push and updates coming, I think ultimately you need WHO guidelines, and you need them to be behind what we're doing, or we really have a much harder time selling things in countries in terms of new agendas.
I think you said it right. We do have a harder time selling things. I mean, our program in Peru has moved much more slowly than it needed to because everybody's waiting for WHO. We wait a long time for some of these new innovations to be introduced or to be used more widely. But once you have that WHO recommendation, it's also very valuable. Can I have some questions for the panel?
Thanks, Koki Agarwal, MCHIP. I had a question, and anyone from the panel is welcome to answer it. And my question relates to the training for just PPH-specific training. When MCHIP works in many countries, the reaction from the government is that if you're going to train people, why don't you train them in the basic emergency obstetric care or the comprehensive, which is what the government has endorsed and is wanting to do. And they don't look very favorably on just picking out a specific complication of pregnancy and doing training, pulling out people to do training for that. And I wondered what has been the experience of either the panelists or anybody else from the audience.
Yeah, I think this is a very interesting and valid question. Certainly for Nigeria, even though the government would prefer to have the whole 3-week training on EMOC, it's very difficult. Most hospitals cannot afford to release their midwives or their doctors for 3 weeks. So I think we have been able to come up with ours. It's not only a training on PPH, but also a training on eclampsia and magnesium sulfate. And we reckon that between the two between the PPH and eclampsia, they constitute about 50% to 60% of the causes of maternal mortality. So it's usually easier to convince the government to release their workers for a 5-day or a 1-week training, rather than to release them for for the whole 3 weeks for the EMOC training. They will usually say that it's better for them to do that, but when you rationalize with them that you don't really have a lot of people and it's not really wise to allow them to go for a very long time, they usually see reason with that and they release them.
Okay, thank you, Farouk. From my own experience trying to train Francophone countries for the last 10 years in EMOC, I think it is the same feeling in the country. When you talk about just having a training on PPS, they say, oh, Dr. Dao, you want to waste the time of our providers. Let's be more comprehensive. Is a basic or comprehensive EMOC? Yes.
Debbie, go ahead. You want to answer some of it?
Yeah, no, I want to speak to this because I think, again, this is where we need to think outside the box. And I think some of the earlier speakers spoke to it. I mean, Sushi Engelbrecht is a midwife who has done work with membership, work with Cathy in Francophone countries, and I think a lot of us know her. And she has been recently working in DRC, and she said that some of the stuff that she really thinks we need to be doing more of is, it's a specific skill. And on-the-job training, kind of midwife to midwife, maybe having, I think they do need to understand, the principles behind it, and they need drills and things like that. But I think it doesn't always have to be a 5-day training. And how can we come up with other ways, particularly when they're individual skills, and then having supportive supervision? And I think we all need to be looking at that, because we can't afford it, number one. And as we can hear, the government has legitimate concerns and complaints about taking people out all the time and wanting a more comprehensive. I also wanted to speak to what Lami was saying earlier about monitoring and evaluation. And you had 3 things listed there, but one of the things you didn't mention that we're really working on, and it's more of a comment, it's the whole issue of indicators, that we really need indicators to track our work in AMSTL, in PPH prevention, and that we've got to get it into the HMIS. So we've got ongoing work with WHO on trying to get some agreed global indicators in this arena, because ultimately if we don't get it into the HMIS systems, it really isn't going to be anything governments and on a national level they're going to track in a way that we really want to be able to see impact.
Good comment. I saw some questions over here. Or, Sudhir, did you want to answer?
Regarding this EMOC and BMOC training, because I had evaluated EMOC training in India. The experience is, EMOC training is for 16 weeks in India, 6 weeks at medical college, 10 weeks at district hospital level. It's a huge training. And at the medical college level, for the participants, they are not getting any experience for doing cesarean sections. All the PG students, residents, they are doing busy conducting cesarean sections. The participants are just observers. When they go at the district hospital level, there is not a single cesarean section happening at the district level, because there is no blood storage unit. So that's the quality of training. That is why the BMOC and EMOC training has some problem or issues. BMOC training, there is a 2 weeks training. And there is no practicum in the labor room. It's only theory, sitting in this lecture hall. So what's the point in that training? It's a theoretical training. That's why the quality of BMOC and EMOC training has issues. Another thing is why we need WHO recommendation for each and everything. WHO has done polio eradication activities since 12 years. Whole health system in Nigeria and India, it's completely paralyzed. In every month, 15 days, all health workers are busy in going house to house immunization for this polio eradication drive. For each, why we need, because this is, we have to introspect ourselves. Why we need recommendation for everything? There is plenty of research for misoprostol. I don't know. This is.
We should get rid of WHO.
Yes, in this room we're just thinking about obstetrics and PPH, but keep in mind all of the other trainings that government workers attend, not just PPH, not just obstetrics.
Excuse. Okay.
Hi, my name's Katie Donahue from URC, and as we're talking about trainings, I love the idea of the drills. I think that's really great. I was just wondering if these are occurring at all the levels, district level and then the country hospitals, or how often you think that this stuff should be occurring, and you know, who should be leading these things as well. Should it be done by outside organizations or by Ministry of Health staff?
Okay. Thanks for the question. I think the drills need to be tailored for the different levels where they are, as well as the context. You know, an urban primary health care center is going to have different needs than a more rural primary health care center. So the level is one thing, but also the context in which it's happening. I think that ministries of health should be implementing these. When we're coming with an outside training, we build a drill into the outside training, but then it needs to be carried on. And I think ministries of health, as well as the professional associations, and as we were talking about, the pre-service education, so that it's institutionalized within the system and not something that's brought in from the outside. And frequency depends on volume. If you're being exposed to cases, you don't need to do drills as much. If you're never exposed to cases, you have to have lots of drills, so you're ready for that one real case that comes in.
Okay, were there questions on this side? Yes.
Yeah, it's sort of a question and a comment. Getting back to the pre-service issue, I think there's the same problem of training where if you're taking, you know, several clinical faculty or classroom faculty away from the classroom to train them, and then there's no one left to teach the students. But then even if you just take, the problem that I face is that you take 2 or 3 faculty from each school and you put them through an intense training, how then does that knowledge and those skills get transferred to the remaining faculty? And we always think that, you know, they'll transfer the skills, but they don't have the time, and they often don't have the resources to do simple things, even like photocopying the materials and having the time to sit down and transfer a 2 or 3 or 4 week training to their fellow faculty persons. So I just wonder, you know, particularly to Dr. Blamy, but also to the others, you know, how can we address that? Because in all the pre-service trainings that I've done, you have 2 or 3 faculty from each school, and there's no way that the rest of the faculty end up benefiting in a real way from that.
Dr. Blamy.
I think right now, as far as West Africa is concerned, through the West African Health Organization, there is a global revision of midwife, nurses, and medical student curriculum. One of the, I am not sure, you can revise the curriculum, but nothing happened after. I hope that through that revision, we'll be able to move, because ultimately the most important issue is to have the skill when you need it. I would like to elaborate a little bit on the indicator issue. I think one of the mistakes program has been making for some years now is that when there is a program in a country, they bring their own indicators with 2 systems running parallel, the program indicator and the country indicator. So as you said, we need to have this indicator within the National Health Information Management. Otherwise, at the end of the program, no more indicator. Okay.
Hey, Dr. Hadi.
I would like to, since I'm having this in my hand, I want. Yeah, I thank you so much for the really very impressive presentations. Thanks a lot. It's very inspiring. And I must say that since 2 of the eminent policymakers, or at least in connections with policymakers in West Africa, my question is really related to the recent few years of the African Union commitment to the maternal mortality prevention. And they made like very impressive involvement or statements in that they are very, very supportive, and they are paying a lot of attention to this, and they promised that they are going to have that trickling down to the different government and different countries. So I would like to hear your feedback, or how that policy or political will from the African Union is going down to the implementation at the policy level to each government? And is there any, the governments, did they show like strong political will to reduce maternal mortality? Thank you.
Good question, Hadi. That's yours again.
It's yours.
I think you mentioned West Africa. The region I know, the other part I don't know very well. I think few things are going on. One of the major issues discussed, which is being discussed right now there, is the issue of financing maternal and newborn child health. Most of the government may be moving toward a free maternal and child health services, but we must be very cautious. Because from the last 5 years it was subsidized, now they want to make it free. Using, they have been sensitized by human rights activists saying, okay, maternal mortality is unacceptable, it should be a human right issue, so they are trying to move to free. But even when you say free, somebody has to pay. That's the issue. Okay, what can I say?
Answer. Okay, we're going to take a quick, whoops. One more? Do you have time for one more?
I think, did you want to speak to that?
Go ahead, Farouk.
Yeah, I just wanted to say, something in support of the free maternal health program. In the Nigerian context, it's very fashionable now for different state governments in Nigeria to proclaim that they are offering free services for maternal and under 5 health care. But you do find out that the quality of care that they are really offering for free is very, very poor, and I hardly think that quality of care can make any difference in the mortality, in reducing mortality that we're talking about.
Okay, can we take a pretty quick break? How about